AAMG. Your choice, your health, our mission.
So I think we have viewers who would like to learn more about the diagnosis of COPD. So I think some viewers learned that using pulse oximetry could be one method of diagnosing COPD. And how's that work? Since some patients actually had at home.
Pulse oximetry can be used almost like a vital sign such as temperature, blood pressure, heart rate. So you can use it to follow COPD, to evaluate for COPD, or to suspect it. You can have low pulse oximetry for other reasons. It could be from heart failure, pneumonia, asthma, not just COPD. But if you have low oximetry values, then you need to find the reason. So if you have a diagnosis of COPD, then you can use that and follow to make sure your oximetry levels are normal. If you have one at home and you get low values, then you may come back to the doctor and say that at home I'm getting numbers in the 80s, and that person may qualify for home oxygen. So it helps you be suspicious of it, it helps you evaluate it and then follow it. I would use it just like a vital sign. I check my blood pressure, heart rate of the patient, and your oximetry levels as a vital sign.
So it's more like the management of COPD, not quite diagnosing COPD. Is that right?
It's great for evaluating and following and managing and make sure that they've got normal oximetry levels. The pulse oximeter also measures your heart rate. So if they have a fast heart rate for whatever reason, then it can evaluate that too.
So this is one method of whether or not the patient needs oxygen or not. So that is a really key determination.
Just to qualify for home oxygen according to Medicare, your oxygen level is 88% or less in general, whether it be resting or walking or sleeping. If it's 88% or less, then you will probably qualify for home oxygen.
I see. Is it one time measure or have to be a few days measure in order to qualify?
Yeah, just one time, even for a few seconds. You may be 94% sitting in a chair, and once you're up and walking, it drops to 88, then you would qualify. You could qualify, then you have to wear the oxygen in the lab and make sure the oxygen level on the oximetry comes up again to make sure that you do benefit from oxygen. So Medicare requires 3 numbers: the oxygen level while you're resting and while you're walking, and then with oxygen level with oxygen on. So the best place to do that is in the hospital where they can provide oxygen for you for the test.
I see. Yeah, thank you so much for the clarification.
Okay, sure.
So Dr. Holm, how do you feel about the presentation? Do you have anything to add?
Most of it's pretty good. There was one slide about lung volume reduction surgery and transplant. I haven't had a patient do that yet, because when we get to that point, you definitely need to see a pulmonologist first and go through pulmonary rehab, optimize your treatment, because that's the last resort. And there's also something called bronchoscopic lung volume reduction, which I don't do, but I refer to UCSF. So it's nice to know, but I don't want a patient going to their family practitioner saying, I want surgery for my emphysema. There's lots of steps to do before you get to that point. Again, most of my patients with COPD, they're elderly, they're pretty frail, or there's no way they can go for lung transplant or even do lung volume reduction surgery. It's good for them to know about it, but there's so many things you can do before you get to that point.
So for what is COPD, there's 2 categories. One is chronic bronchitis and another one is emphysema. So would the patient have progressively from chronic bronchitis and then eventually have emphysema or vice versa?
Well, we also used to be taught that asthma is part of COPD. So now we try to separate that out because the treatment can overlap. But if you have chronic asthma, then that can lead to emphysema also through biological changes. So the way the slides are now, they're fine. You did mention asthma later on, because a lot of my patients have overlap with COPD and asthma.
I see. So is any a treatment or a method to prevent asthma developing into emphysema, or we don't know how to do it?
To prevent asthma from developing into emphysema is to optimize your asthma, treat the asthma. So that's another talk. Many of the medications overlap with COPD, but asthma patients often have more issues with allergies and things that's where prevention is very, very important. It could be house mold, it could be dust, it could be flowers, pollen, it could be dogs or cats. So that is more important for people with asthma. Again, many patients will have both, but people with asthma are more responsive to prevention, avoiding environmental stimulants.
I see. So managing the environmental stimulants will very effective to prevent emphysema down the line.
It can environmental cleanliness is important for asthma and COPD, but more so for asthma in terms of having mold or secondhand smoke or dust and fumes, and again animals. People with asthma are more likely to have issues with the environment. Not like people with COPD can have that also, but if you have asthma, there's a higher risk of being issues with controlling the environment. There are some patients with severe asthma. If they control the environment, their asthma is completely controlled. They might not even need medication. So the key is to find people with COPD and asthma both, and there are quite a few of those. And then you might need to overlap the treatment. So the diagnosis is overlap syndrome with COPD and asthma. So that's important to diagnose that too. And again, that's where you have your history, your physical, and then spirometry, pre and post bronchodilator that can help kind of clinch the diagnosis of asthma with COPD.
I see. Thank you so much for the clarification. So for patients who have asthma and maybe a little bit of COPD, should they see a allergist or should they see a pulmonologist?
Allergists are very qualified to manage asthma. I have close working relationships with many allergists. Once the patients have a significant COPD component, or if they keep getting hospitalized for whatever reason, for respiratory issues, then they should be seeing a pulmonologist also. Allergists usually do not go see patients in the hospital. Pulmonologists do. And so people who continue to have admissions to the hospital for allergies, for asthma or COPD, they should be seen by pulmonologists also. But if they have just purely asthma and it's controlled with, then allergists they're fully qualified to manage pure asthma and sometimes with mild COPD.
I see. That's great. Is there any other lifestyle that you recommend or home therapy that they should have?
So in COPD and asthma, it's you want to also, again, we talked about controlling the environment, we talked about exercise and diet, avoiding being around people who are ill or who may be contagious with things. I had one patient who had problems with the weather in San Francisco and moved to Arizona with nice warm weather, and the asthma and respiratory symptoms were pretty much resolved. So that's pretty extreme. But again, in asthma, also less so with COPD, the environment is very, very important. That's part where the history is very important to get what types of things that people are exposed to.
Mm-hmm. Yeah, that makes sense. Yeah, sounds like hot weather. It's very beneficial for people who have asthma or COPD. Would you see it as a true statement?
Many patients with asthma also have cold-induced asthma. Sometimes it can be exercise-induced. It could be cold. It could be pollutants. So cold weather can sometimes trigger bronchospasm, which is more common in asthma, but also happens with COPD. And then, but having said that, last week I had a patient who said she gets worse really hot or really cold. So again, the history is important.
I see. It makes sense. Thank you so much for your sharing.
Okay.
It's very helpful.
Right.
For more information on other health topics, please visit the AAMG Health Education website. If you like this video, please give a like, and subscribe to our channel for more related content.